Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening and welcome to Hello Health. I'm Tom Bagwell. Good to have you with us. Hello Health is a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about your eyes, the changes they undergo as we age, and problems those changes can lead to, including in some cases, blindness. Our guest is optometrist Kefla Brown. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. That's 866-3200. And by email. You can email your questions to us at hhquestions@wlae.com. We've already gotten one email, and you can send those emails right now. We'll ask you to hold off on the phone calls for just a short while. Well, tonight on the program, we welcome optometrist and New Orleans native Kefla Brown. Dr. Brown received her optometry degree as well as her Master of Science in Vision Science from The Ohio State University College of Optometry after earning her biology degree from Xavier University. Dr. Brown completed clinical rotations at Randolph Air Force Base in San Antonio, Texas, and the Columbus Veterans Administration Hospital Outpatient Clinic. She completed her residency at Ochsner Medical Center and is certified by the National Board of Examiners in Optometry for the treatment and management of ocular disease. Dr. Brown joined Ochsner in 2001, and we welcome to the program the Director of Pediatric Optometric Services at Ochsner. We welcome back to the program, actually, Dr. Kefla Brown. Good to have you back with us, Doctor.
Good to be back. Thank you so much.
Yeah, it was about, what, 2 to 3 years ago?
It
and
was.
The big thing that changed is you got some of your house replaced, is that right?
We did. So Katrina's anniversary is coming up on Saturday. We actually got flooded in Hurricane Isaac, which was, again, August 29, 2012. So we had a little adventure there. And the bright side is new cabinets, new floors.
There you go. And we're all looking back these days at the 10th anniversary of Hurricane Katrina, and not only the suffering that took place, but how we're better as a city.
Exactly.
And certainly
exactly.
A lot of people choosing to look at the positives as we do too. So thank you, and good to have you back with us.
Thank you.
Ironic that I'm working with one eye tonight as we talk about eyes. One contact is working well, the other not so much. So we'll be using the glasses tonight a little bit, but that's okay and probably appropriate for this program. So let's begin with the anatomy of the eye and some of its primary working parts.
That's an excellent starting place. So basically the way that the eye works is whenever we look at something, light comes into the eye. So the cornea is the clear front surface of the eye, and light goes into the cornea. The cornea is responsible for directing light through the pupil. The pupil, of course, is the opening in the center of the iris being the colored part of the eye. So from the pupil, the light is focused onto the lens, and the lens then focuses light onto the retina, particularly in one particular spot called the macula. So the retina is the inner lining of the eye. It's like nerve tissue from the brain. So from there, the retina captures light and sends it to your optic nerve back to your brain so that you can see.
That's how it's supposed to work, and for many of us it does for many years. But as we were talking earlier, when we start to get around 40 years old or so, you said about 5 minutes after you turn 40 in a lot of cases, we start to see some changes. So with age comes what sorts of problems?
So first of all, we can talk about kind of developmental things that come on, particularly nearsightedness and farsightedness. So in nearsightedness, what happens is as we grow, the eyes grow longer and light is focused in front of the retina instead of being focused on the retina, and that makes your distance vision blurry. In farsightedness, the eye is not long enough, so light is focused behind the retina, and when you have enough farsightedness, your up-close vision is fuzzy. So the next thing that'll happen is when we do hit 40, then our focusing ability begins to change. So basically there are two things that happen when we look up close. The eyes turn in to aim at what we're looking at, and then the lens adjusts to focus on things to make things clearer. So when we hit 40, that ability for the lens to change shape and focus begins to go away. And it's a progressive process from 40 to 60. So most people will notice it very shortly after turning 40, and you know, some people may be in denial for a while, but it is a progressive process, and usually by the time we hit 60 or 65, we're just out of the ability to focus, and that's when we're definitely using some type of help for looking up close.
And why are they named oppositely? Why is nearsightedness when you can't see far and farsightedness when you can't see near?
So it makes more sense if you think about it as you are what you see. So you see better up close, you're nearsighted. If you see better far away, you're farsighted.
There you go. Very good. You'll help me get through medical school. How do conditions like diabetes and blood pressure affect our eyes?
So diabetes and blood pressure at their core are diseases of the blood vessels. And basically in the eye, there are tiny blood vessels that branch off of blood vessels from your heart, go up through your neck and into your brain. So with diabetes and high blood pressure, the blood vessels actually start to get damaged and leak, and blood leaks out of the blood vessels. So tissues in the eye and the rest of the body are not nourished properly. When they're not nourished properly, they don't function and they begin to die. And in the retina, what happens is it begins to starve. So there's a really good process that the retina sends a signal to the brain saying, hey, we need new blood vessels. So the brain sends another signal down saying, grow new blood vessels, which seems like a good idea. But the problem is that the blood vessels, the new blood vessels, are leakier than the broken blood vessels. So the retina continues to starve, and that's where we lose vision. In this next slide, we can see that, you know, all the way over to the right there is a picture of a normal vision, no vision loss. In the center, because the retina dies in spots, you get splotchy vision. With high blood pressure, it increases your risk of stroke, and basically you can have a stroke in the brain and you can have a stroke in the eye. Depending on where in the brain you have a stroke, it'll affect usually one half of your peripheral vision or the other. If you have a stroke in one of the smaller blood vessels in the eye, it can actually cause permanent vision loss, either partial or complete, within about 2 hours. So it's very important to get quick medical attention there.
Okay. And how would we recognize that? What would the symptoms of that be to know to get to the hospital quickly?
For a stroke in the eye, if you ever notice your vision going black or gray or a smudge in your vision, some people might think it's a spot on their glasses and they clean it, but it stays there. So a spot in the vision going black or gray, even for a couple seconds, that's probably indicative of a clot or something blocking one of the blood vessels that leads to the eye.
And that's not to be confused with a floater that we might have all the time.
Correct.
Okay.
A floater actually does just that. It floats and it moves around. With the impending blood vessel occlusion or stroke, it's going to be stationary.
Okay, and only because I brought it up, I know what a floater is. I know what it looks like because I have them.
Right.
It seems like I have them occasionally. But what is a floater and what causes them?
So the back of the eye is actually filled with a substance called vitreous humor, and it's a gelatin type consistency. It's actually a suspension. So over time, that suspension begins to break down and pockets of liquid will develop. And what happens is collagen fibers and cells that were once in suspension now float around in those pockets of liquid and cast a shadow on your retina. So that's why usually in bright lights or against a white background we'll see our floaters, because we're actually seeing the shadow of the collagen fibers. Now the problem is when we start to see a whole bunch of floaters or a curtain come over the vision, that's actually a sign of a hole or a tear or retinal detachment. And that's an emergency emergency that needs to be attended to very quickly so that a retinal detachment doesn't progress and lead to blindness.
Okay, but an occasional floater here or there?
Is normal.
Certainly normal.
Is normal,
okay.
Yes.
Well, a disease or condition that many of us will have to deal with at some point, usually not at 40, but maybe a couple of decades after that, cataracts.
Yes.
So for the viewers who don't know, what is a cataract? What causes them, and is there anything we can do to prevent them?
Right. So I prefer to think of cataract not necessarily as a disease, but a progression through life. So basically the lens inside of the eye, like I said earlier, it focuses light onto your retina so that you can see. So when we're born, the lens is clear, and then over time, when we're still young in our kind of early 50s, the lens begins to get more yellow, and then over the next several decades, it becomes more white and opaque. So instead of light coming in and being focused by a clear lens, light is scattered by an opaque lens, and that's cataract formation. So there are ways that we can slow down cataract progression. So basically, it is an aging change that occurs over time. So things that slow down the aging process, such as healthy eating. Don't you love that? Everything boils down to healthy eating. Lots of antioxidants, leafy green vegetables, a good healthy diet, and also protecting your eyes from UV light. So we know now that UV exposure has cumulative damage over time. Just like the UV exposure that we get to our skin can cause sun cancer when later on in life, the same thing happens with our eyes, and those UV rays that we encounter throughout lifetime eventually cause cataracts.
And we'll talk about some of the solutions to that a little later in the program. Macular degeneration, next. What causes it, and what can we do about it?
So macular degeneration is actually one of the leading causes of vision loss in the elderly population. So as you can see in the picture of the normal retina, there are blood vessels throughout the retina that supply the retina with nutrition and blood. Well, there's an area called the macula, and there are no blood vessels through that area because that's where light comes in and it's focused for our central crisp clear vision. So the macula gets its blood supply from a layer of blood vessels underneath it, and there's a tight barrier that separates that blood supply from the macula. Well, what happens in macular degeneration is that barrier starts to break and waste products build up underneath the macula, and the macula becomes lumpy and bumpy instead of nice and smooth. Over time, what can happen is the macula is actually deprived of oxygen, and new blood vessels start to grow and leak and bleed into the macula. So that's the distinction between wet macular degeneration and dry macular degeneration. Dry macular degeneration is lumpy, bumpy, waste products building up underneath the macula. Wet macular degeneration is proliferation of blood vessels that are causing leaking and bleeding into the macula.
Okay. Talking about blood vessels, when we have a red eye, we can buy things over the counter like Visine and other products such as that. So what is the red we're seeing in our eyes, and how do those help?
So on the front surface of the eye, it's very different from what's sometimes going on inside of the eye. So on the front surface of the eye, when the eyes are red, it basically means that something is happening to irritate the eye. The blood vessels get engorged, they get bigger, and that's where our eye gets red. It could be from a number of things. It could be from environmental irritation, it could be from inflammation, it could be from an infection. But basically, most people, the first thing that they do is they run to get the red out drop like Visine or Roto drops or something like that. And it's a temporary fix in that basically it constricts the blood vessels, but it doesn't actually address the problem.
Right.
So over time, just like using a nose spray to decrease decongestion, if you use the nose spray too much, you're going to get a really bad stuffy nose. Same thing happens with the blood vessels on the front of the eye. After continuous use of Visine, those blood vessels stop responding to it, and you get a red eye that's really hard to get rid of. So most dry eyes, as we see on the screen now, most dry eyes actually, most redness rather, is caused by dryness or tear film insufficiency. So there are actually several layers to the tears, 3 layers to be specific. And there's a bottom layer of mucus that sticks the tear to the eye. There's a middle layer of the liquid tear called aqueous that is actually the bulk of the tear. And then there's a top layer of oils that actually coat the tears and the eyelid margins to keep the tears stable. Those oils also protect the eyelid margin from overgrowth of normal bacteria. So if one of those 3 layers is not working properly, then we'll have tear film dysfunction. Tear film dysfunction can also lead, ironically, to a teary eye. If an eye is not moisturized well, then the eye overproduces faulty tears to make up for it, and that's where we get some tearing sometimes in dryness. Most people will notice when their eyes are dry that it feels like a rock is in their eyes, and you just can't convince them that there's nothing in there. So the best thing to actually use for symptomatic dry eye to get rid of the symptoms immediately is an artificial tear. Some type of get the red out drop. Examples might be Sustain or Refresh or Genteel. There are even generic versions because they can get a little pricey. But using an artificial tear is going to be your first line defense. Nutritionally speaking, increasing your omega-3 intake, like fish oil or flaxseed oil, is going to go a long way to decreasing inflammation in the body, but also on the front surface of the eye. And decreasing inflammation is going to help your tears to be produced better. Along the way there, dehydration is, a common cause of dryness everywhere. So increasing your water intake is going to help with that also. So there are lots of systemic diseases and systemic conditions that can contribute to dryness. Estrogen plays a very important role in the front surface of the eye. So as we lose estrogen, things become a little bit drier. So supplementing with artificial tears. There are some medications in severe or dry eye, anti-inflammatories and things like that, that will help in severer cases. But in general, we want to stay away from get the red out drops and at least start with an artificial tear and maybe altering diet and nutrition.
You mentioned the cost of those artificial tears. Saline solution is relatively inexpensive, but that's not artificial tears.
No.
It is moisture and can get you some temporary relief, as it does for me in the middle of the night on occasion when I leave the contacts in. But you said there are coupons that some advise your patients and would advise our viewers to go look for.
Exactly. So the difference between saline and an artificial tear is the saline will rinse the eye, make it wet temporarily. Artificial tears, particularly the ones that are available now, will actually bulk up and reinforce the different layers of the tears. So yes, artificial tears can be expensive, but there are coupons available. Most optometrists and ophthalmologists will have them, but you can do a search online. For example, Sustain has a website that you can go to. Refresh has a website that you can go to that you can get $3 coupons for artificial tears, and that goes a long way in helping with the bite of the cost of artificial tears.
Good to know. Well, let's talk about inflammation from diabetes and arthritis and other diseases and how that can affect production of tears.
Right. So inflammation basically disrupts that bottom layer of the tear, the mucus that kind of sticks the tear to the eye. So inflammation on the front surface decreases production of that mucus, so the tears aren't adhered to the eye very well. And that is when we'll get a lot of redness and irritation and, quite frankly, disruption that really affects your life. So those are the medical causes, the more severe forms of dry eye. And for those, you'll find yourself using artificial tears quite often. So really, if you're using an artificial tear more than 3 times a day, then we have a more moderate to severe dry eye that needs to be addressed, perhaps with a short course of anti-inflammatories. I'm sure most people have seen commercials for Restasis, which is appropriate in some situations, but there are medical things that we can do other than just over-the-counter artificial tears. Artificial tears always have a place, but sometimes in more severe conditions, there's more that we can do to make you comfortable.
Yeah, and what are some of the other complications associated with dry eyes and risk for dry eyes?
So complications with long-term dry eye, and particularly conditions that are inflammatory in nature, like rheumatoid arthritis or Crohn's disease or other things with the autoimmune diseases that cause inflammation, you can actually get a lot of scarring of the cornea. And of course, if the cornea scars, then you're not able to see through it well. So they can actually lead to scarring and poor vision. Now, as far as what you can do about it, again, changing nutrition and talking to your doctor about kind of short and long-term solutions.
Okay, let's talk about children's eyes and some of the problems that children may have to deal with their eyes.
Yes. So most people will not necessarily consider, checking a child's eyes. They'll wait till symptoms arise. But there are lots of medical conditions that are common that will also affect the development of eyes. Some of them are neurological conditions. For example, when a baby is developing inside the mother, there's a chance of stroke inside of the uterus. So that can lead to vision problems, just like a stroke, in an older person can lead to vision problems. Same thing, it can cause eye turns, it can cause decrease in peripheral vision. There are lots of genetic disorders that will cause eye problems. Inflammatory bowel conditions and GI conditions will cause problems. Juvenile rheumatoid arthritis. Concussions are a big thing. With so much emphasis on sports nowadays, we're getting a lot of concussions. And though eyes actually are very crucial in telling how severe the concussion is and also gauging when we're recovered, because there's an intricate connection neurologically between the eye and the brain, and testing some of those functions is going to be crucial to that recovery process. Speaking along those lines, getting a good baseline exam before we go into sports and such.
A lot of schools are doing that now.
Yeah, it's going to be crucial.
Now, is that one of the reasons you talked about the connection between the eyes and the brain and concussions? Is that one of the reasons for concussions they tell you to shut everything down?
Yes.
You're even being in a dark place.
Right. So
no sensory overload, certainly.
Exactly. So one of the main treatments for concussions is what we call brain rest, which unfortunately since most of the people who get concussions that I see are teenagers, brain rest is near impossible because they think I'm not studying, but then they're texting and whatnot. So brain rest, right. Exactly.
Yeah.
It's difficult but necessary to give that brain, give the neurons time to kind of replenish and rejuvenate themselves.
I know something else you wanted to talk about tonight, very important, the connection between eyesight and learning.
Yes. So basically, one of the things that we look for in a complete eye exam is to make sure that the eyes are aligned. Okay, so there's a difference between being able to see 20/20, being able to see clearly far away, and be able to use the eyes properly together. So ideally, our eyes, when we're looking straight ahead, are actually, the muscles are aiming the eye straight ahead, and then when we look up close, the eye muscles have to aim the eyes together. So obvious binocular issues are when one eye is looking at the nose, or eye turn in, called esotropia, or an eye turn out, that's exotropia. Any mother who sees that, they're going to bring their child in for an exam. But there are more subtle issues where the eye's natural resting position may be more in or out, and that will create problems with tracking, especially up close. So for example, if the eye's natural resting position is more out, all day long the eye muscles are working to keep the eye straight ahead, but when we go to read, then the eyes have trouble aiming up close. So if the eyes can't track past right here, then our normal working distance is usually right here, everything becomes double. So it's very difficult to learn to read, to decipher, to comprehend when the brain is actually trying to put together basic information. So there are a lot of cases where binocular vision problems can mimic learning disabilities. So it's a good idea that's one of the reasons that it's recommended to have a baseline eye exam before school starts, and we'll talk about eye exam recommendations a little bit later.
Yeah, and is this the test where I'm going in, where the two squares are coming, you say, okay, tell me when they're lined up,
that is one of the tests. That is one of the tests, yes. Yes.
Okay. As far as children and checking eyes, it's been a while since my kids have been in elementary school, so I don't know if that's happening anymore. But I know at some point, I think I remember it back in the Jurassic period when I was in elementary school, that they'd come in and they'd give you an eye test, and it didn't last very long. And with as many students as are in schools today, you'd think, they do the 30-second, okay, can you read that line? Can you read that line? Okay, good. But what you've just described is a lot of other issues.
Correct.
Beyond just, can you read, what line can you read?
Correct.
So are schools doing their part, and what should parents be doing?
There are about 9 different visual skills needed for academic success, and most vision screenings will check far away, your distance vision, whether or not you can see something far away. We also need to assess whether or not your up close vision is working, whether or not the focusing system is able to adjust from far away to up close, the alignment of the eyes, processing issues, things like that. So most good vision screenings will check distance visual acuity, up close, and maybe an assessment of alignment, but that's rare. So it's important that we get a good eye exam to address whether or not ocular health is developing properly, whether or not the anatomy is straight, because we can also kind of predict sometimes whether or not a child will become nearsighted, whether they're going to grow out of farsightedness. We can kind of predict problems early on and take earlier steps to avoid complications.
Any of these based on the environment, and what has all of us now carrying cell phones, and not just for calling people, but reading and texting and everything else, is that changing the way our eyes develop?
It is. So as a mother of two kids, I'm very aware of two young kids. I'm very aware of this kind of position right here. Everything happens on the Kindle or the iPad or the phone. And basically over the past several decades, there's actually been an increase in prevalence of nearsightedness in kids whose parents are not nearsighted. So there's definitely a genetic link between nearsightedness and, development of nearsightedness and genetics. But because of our kind of shift indoors and our shift to more things up close, then there's an increase in the prevalence of nearsightedness because we're no longer out hunting anymore. We've kind of shifted our needs. Right. Exactly. Yeah. We've shifted our needs. So there is a change that's evident.
And, we were probably reading books, although I probably didn't read as many as I should have when I was young. And now they're not reading on books anymore. They're reading on other things. And there's all sorts of studies out there that show the brain works differently, because a book is right here too. Right. But the difference is reading on a piece of paper and reading on a tablet or a smartphone is very different for the brain. Our brain is wired differently. It's becoming rewired because of this.
And, with the lighting that's involved with the tablet, sometimes, with angles, if there's glare, so sometimes that can cause eye strain, not permanent damage, but eye strain. And if there is some hidden farsightedness, then that can cause headaches toward the end of the day. If there is a propensity for nearsightedness, then that can kind of sometimes spur that nearsightedness on. So there are lots of different issues that need to be addressed when we're dealing with up close work. And when we were growing up, we basically went to school, did our homework, went outside for, until dinner was ready. And nowadays, there's not so much, letting your kid free to go explore the neighborhood. There's a lot more academic work. We're learning to read earlier. We're learning everything earlier. And then everything's on computers and tablets. So it's not that we can avoid the electronics anymore. So it's something that we're definitely seeing changes in patterns and diagnosis in clinic and treating accordingly.
Well, and one of the positive things we want to talk about tonight is some advances in the way we treat nearsightedness.
Yes.
So tell us about those.
Yes. So basically, if we can start with how the eyes develop. So basically, when we're born, everything is short and small, and the eyes lengthwise in the head are actually very short. Babies are born with a lot of farsightedness, and the goal is as we grow taller, the eyes grow longer and we grow out of that farsightedness. So studies have shown that if somewhere between 3 and 7 there's a little farsightedness left, when we hit the growth spurts in middle childhood and teen years, then we grow out of the farsightedness. The problem with nearsightedness is we hit the neutral point too early, and then as you continue to grow through childhood, the eyes get longer and longer and longer, and that's where progressive nearsightedness comes in. So recent studies have shown that if we can detect a little nearsightedness very early and use a multifocal contact lens or a bifocal pair of glasses, and there are some other different contact lenses that can be used in this case, we can actually slow down progression of nearsightedness. Won't go away, may progress a little bit, but the end point is going to be a lot less than had we just kind of let nature take in its course.
And what do we see here in these images that you brought?
So the first image shows how nearsightedness works. So basically light comes in and light is focused in front of the eye. In traditional glasses, what happens is because traditional glasses have the same power throughout the lens, light is focused now on the center of the retina, but light coming in from peripheral, from your top, bottom, and sides, they're actually focused behind the retina, and that actually stimulates the eye to go longer to catch those peripheral rays, which therefore increases nearsightedness. In that final picture, what happens with corrective lenses and myopia control is that light is focused on the central retina, but the peripheral or the edges of the correction of the lens or the glasses or contact lenses actually adjust light so that they're focused in front of the retina, and it decreases the stimulus for the eye to grow longer, thereby decreasing progression of nearsightedness.
All right. Just a moment, we're going to talk about vision therapy, helpful or a fraud, and we'll also talk about when everyone should be tested for eyes, starting at the earliest age and then beyond. But first, we want to invite you to call us with your questions. The time to do that is right now at 504-866-3200. That's 504-866-3200. Or you can send us questions by email. Just go to hhquestions@wlae.com. That's our email address. Well, doctor, let's talk about vision therapy. I remember somebody telling me that, you know, if you do these eye exercises, you might be able to work your way out of the glasses or at least improve your vision. You said at least one person who was part of this movement is behind bars now. But you said in some cases it can be helpful for some kind of issues, right?
Correct.
So somewhere in the middle?
Correct. So basically, vision therapy for ocular alignment issues, eye turns in, eye turns out, and basically coordination issues is very good, very legitimate. In some cases, not all, but some cases we can avoid surgery. Okay, those types of vision therapy actually retrain the nerves to control the eye muscles better. What was popular at one point was, for example, the See Clearly method, which claimed to use different eye exercises to get rid of glasses so that if you're nearsighted you can see better, if you're farsighted you can see better. That is what's not legitimate. So that's actually what's been taken off the market, and legal implications have come to its proprietor. So vision therapy for binocular vision issues, alignment issues, eye turns in, eye turns out, and coordination and tracking issues is very beneficial. Vision therapy also for what's called amblyopia. Amblyopia is actually commonly known as a lazy eye, where the connections between the brain and the eye are not developed properly. And it's usually because of either an eye turn in or out, or an unequal amount of nearsightedness or farsightedness in one eye. So once that issue is corrected, then vision therapy can actually help to encourage the connections between the brain and the eye. And that's actually something that has to be addressed pretty early in life. There's a critical period of development that takes place between birth and about age 9 or 10. So a lot of these things, if they're not caught early enough, then our treatments aren't going to be as effective. Same thing with myopia control or slowing down nearsightedness. If it's not caught early enough, then our treatments aren't going to be effective.
Okay. And to wrap up this first part of our program, let's talk about when someone should get their first eye exam as a child and how often that should happen throughout our life.
Sure. So the American Optometric Association actually recommends that the first eye exam be at age 1. And the reason for that eye exam is to make sure that anatomy is developing properly, that we don't have any risk factors that would prohibit the neurological connections from developing between the brain and the eye. It also, we can also gauge whether or not we've got enough farsightedness. If you remember, babies are born farsighted and at age 1 are supposed to still be farsighted. So we can gauge maybe whether or not we're growing out of it too quickly or not growing out of it quickly enough, and we can kind of get good baseline data to affect future development. And if everything's okay, then next eye exam should be at age 3 and then at age 5. Now, if a child has nearsighted parents, it's very important that by age 5 they're getting annual exams, because if we can catch nearsightedness below 2 diopters, then we can really have good effects with our current treatments in slowing down that progression of nearsightedness significantly.
And that treatment would be what?
That treatment would be multifocal contact lenses or glasses.
All right.
Yep.
Well, we're going to take a break and we'll be back with your questions. Our guest is optometrist Kefla Brown, and our phone number is 504-866-3200. That's 866-3200, or email questions to us at hhquestions@wlae.com. Back with your questions in a moment. This is Hello Health on WLAE.
So who's going to do what?
I'll pack the dead batteries.
Great. I'll only put what I don't need into a duffel bag.
Perfect. That's totally unhelpful.
No problem.
Meanwhile, I will try to comfort everyone by speaking in a calm voice. And who is going to handle supplies?
I can forget to do a list for us.
Thanks, pal.
We couldn't be any less prepared. I'm proud of you guys.
Talk to your kids about who to call, where to meet, what to pack. Visit ready.gov/kids for tips and information.
I needed help finding a doctor.
PACE.
I needed help with my medication.
PACE.
I needed help getting around.
The Shirley Landry Benson PACE Center is a place that helps seniors remain in their homes providing the care they need. If you or a family member are over 55 years old, you may be eligible for benefits offered by PACE. For more information, contact us at 504-835-0006. PACE, caring for those who cared for us.
And welcome back to Hello Health on WLAE. Tonight we're talking about your eyes and how they're affected by age and other conditions. Our guest is optometrist Kefla Brown. And now we go to your questions. Let's start on line 3. Carolyn is calling us from Gretna this evening. Carolyn, welcome to Hello Health.
Good evening, Dr. Brown. I would like to ask you to please discuss optic neuropathy. That is non-arteritic ischemic optic neuropathy. And, what is the cause? Is it genetic? And are there any new developments in the treatment? And I'll hang up and listen. Thank you.
Excellent.
Thank you, Carolyn, for your question.
That's a very good question. So the question was actually about non-arteritic optic neuropathy. Optic neuropathy is simply a term that means there's something wrong with the optic nerve. The optic nerve, if you remember, is what connects your eye to your brain. So what happens with this kind of ischemic and non-ischemic optic neuropathy is some type of way blood flow to the optic nerve is stopped. Usually it's because of a blood clot, and that's often related to high blood pressure. So basically, the heart divides into several blood vessels, and our carotid artery comes up through the neck, through the brain, and it's that artery that supplies the optic nerve and the inside of the eye with blood. And in cases of high cholesterol, then the blood vessels will be lined with plaques and cholesterol, and sometimes a little cholesterol plaque can get loose and it'll flow through the blood vessels until it gets lodged in one of the tinier blood vessels, and quite often that's one of the blood vessels that leads to the eye. Now, in most cases of optic neuropathy, ischemic or non-ischemic optic neuropathy, the actual event is not something that's noticed. It's actually something that's picked up on testing later on. So as far as treatments for optic neuropathy are concerned, basically a lot of it is preventative. A lot of it is controlling the systemic condition, controlling high blood pressure, reducing cholesterol. After the fact, unfortunately, the optic nerve or a section of the optic nerve has actually died, okay, and it's brain tissue, so brain tissue is not something that can be regenerated. So there are some instances of optic neuritis, which is an inflammation of the optic nerve, which can be treated, but once you have blocked blood flow and oxygen to the optic nerve, then the optic nerve, part of it dies, or the complete optic nerve dies, and that's actually, there's not much that can be done after that.
Okay. Carolyn, thank you for your question. It was a good one. Good to hear from you this evening. Let's go to line 2. Ray is calling us from Metairie tonight. Ray, you're on Hello Health with optometrist Kefla Brown.
Hi, Dr. Brown. Thank you very much for the show y'all putting on. We're enjoying it very much. I had cataract surgery done on both eyes a couple of years ago, and since the cataract surgery, I keep suffering from dry eye, and I was just wondering, why is that? What causes it? And I'll hang up and listen. Thank you so much.
Excellent.
Thank you, Ray.
So over time, the front surface of the eye actually becomes a lot drier. And a lot of it has to do not necessarily with the fact that we had cataract surgery, but with coincidental changes that occur in lid position as we age. So as we age, you know, the skin around your skin on your whole body isn't quite as elastic, and actually the muscles that kind of keep the eyelids closer to the eyeball actually begin to get weaker, and those eyelids actually fall away from the eyeball. The problem there is that good eyelid position is necessary for tear function, okay? So every time we blink, the eyelids zipper shut from outside to in, and tears are drained through the tear drainage duct here. So without that good eyelid position, the tears are not going to be made properly, and the tears are not going to be drained properly, and that's going to lead to subsequent inflammation of the front surface of the eye, which is going to lead to poor tear production. Also conditions such as any inflammatory condition, arthritis, particularly rheumatoid arthritis, will cause inflammation on the front surface of the eye. And then over time, the front surface of the eye just doesn't adhere to tears very well. So over time, we just get a drier eye.
So is it possible, though, that there's any connection between maybe a cataract surgery that didn't go well, or is it always going to be just?
It's usually more related to age-related changes of the ocular surface and the eyelid position.
Okay, and his options would be artificial tears.
Options would be artificial tears, and if it's a severe inflammatory dry eye, then use of prescription anti-inflammatory drugs and drops and possibly Restasis.
Okay, Ray, thank you for your question. We appreciate it. Line 1, Stephanie's next, calling us from Lacombe. Stephanie, welcome. You're on Hello Health. Stephanie, are you with us? Stephanie? Looks like we may have lost Stephanie. Let's go to line 4 next in Gretna, where Jesse is calling us tonight. Jesse, you're on with optometrist Kefla Brown. Go right ahead.
Thank you. I'm calling for my wife. She has macular degeneration, and she's getting injections. And last week, she has a cataract on that eye, and they took it off. And I'm just wondering, will these injections that she's been getting, is that something that'll be an ongoing process for who knows how long?
Yes, usually that's a very good question. So nowadays with macular degeneration, one of the things that we can do, and actually the most common treatment now, is injections of medication that actually stops the blood vessels from leaking. Okay, years ago, even 10 years ago, that wasn't possible. So now we actually have treatments that will stop the proliferation of new blood vessels and will decrease swelling into the macula, and that's what causes the vision changes. So cataracts are an age-related change separate from macular degeneration. So once we remove the cataract, then that's kind of an end-stage treatment there. But with macular degeneration, because it's a progressive condition, then the treatment is going to have to be continuous also.
And those injections take place where? Into the eye itself?
In office, yes. Yes, into the eye itself. It's actually aimed at the retina. It's done by a retinal specialist.
Okay. And when I hear eye and injection, that's not a comfortable feeling.
Correct. So it's not most uncomfortable, okay? So it's not anything where the patient is put to sleep, and I guarantee you there are no screams coming from the procedure room. So it is something that
it's all numb.
Yes.
Yeah.
So it's something that's done in office. Patient is awake. It's not comfortable, but the benefit of it does being able to see better. Because now with macular degeneration treatments, with these injections, we can actually improve vision a little bit. Whereas before, it was treatments with laser to try to slow down the inevitable.
Right. Okay. We hope that's helpful, Jesse, to you and your family. Stephanie is back with us now on line 1. Stephanie, you're on Hello Health. Thanks for calling back.
Hi. Thank you for taking my call. Am I here now?
You're here now.
Hi, thank you so much. I'm so happy for you to take my call. I've had, the last couple of days, I've had things floating in my eyeball, and I Googled it, and it said that it's eye floaters, and it's nothing that's really serious, and it comes with age. I just turned 60, and I want to know what causes it. Is it something that I need to concern myself with? Is it going to go away, or what can you tell me about that?
Sure. So that's a very good question also, and I'm sure lots of people experience the same thing. So as I mentioned early in the program, the back of the eye is actually filled with a substance called vitreous humor, and it's a suspension. So it's tightly attached to the optic nerve, and it's tightly attached around the edges of the retina. So over time, pockets of liquid will develop in the vitreous, and collagen fibers and cells will come out of solution and float around. And those are our normal floaters, and they come over time. So as this liquefaction process continues, the vitreous actually becomes less solid and actually begins to fall in and collapse in on itself, and it pulls away from its attachment at the optic nerve. At that point, we'll usually see a big floater. Some people will think it's like a hair in their eye or a bug, and it's usually accompanied by lots of flashes of light. So if you're noticing new floaters, even if they are not quite as alarming, it's a good idea to get it checked out, because we have to make sure that they're normal floaters and not a sign of a hole, a tear, or a retina. Because if it is a retinal issue, then that needs to be addressed pretty quickly before it progresses to a full retinal detachment, which can lead to permanent vision loss or blindness.
All right, Stephanie, thanks so much. Appreciate you calling back. Our phone number is 504-866-3200. That's 504-866-3200. We do have a couple of open lines, so feel free to give us a call. Let's go to line 2. Victoria is next, calling us from New Orleans. Victoria, you're on with Dr. Brown.
My question is, I had cataract surgery about 3.5 years ago, and I was told that they are growing back. I had never heard of that before. Is that possible?
So a simple way of describing the vision, the blurring of vision that occurs after cataract surgery is to say that they're growing back. So what's actually happening, however, is once we have cataract surgery, there's an implant that's placed into the eye to take the place of the cataract that we're taking out. And several weeks to several years after cataract surgery, a membrane will grow over the back of that implant. I usually liken it to the body trying to make the implant part of itself. And that membrane will actually start to cloud up vision. And that's called posterior capsule opacification. And that is what some people will refer to as secondary cataracts. So there is a treatment for that, and basically it's an in-office treatment done with a laser, and it basically zaps that little membrane away. And once that takes place, then there's nothing that actually grows back again. So cataract treatment actually can be thought of as taking place in 2 stages. One, the initial surgery where we get rid of the cataract, put an implant in, and then usually weeks to several years afterwards, a membrane will grow over, and then a laser zaps that away.
Wonderful question, Victoria. Thank you for asking it tonight. Another Stephanie on the line, calling us from Slidell this evening. Stephanie, you're on with Dr. Kefla Brown.
Hi, good afternoon. I sure do appreciate you taking my call.
Thank you.
About 5 days ago, I had laser for a small hole in my retina. The I have to ask you is that I still feel like a little pain in my eye. And I was just wondering if that is normal. It's like something is in my eye, that it's not like all day long it hurts, but just like off and on during the day. I don't take any drops for it or anything like that. I do have macular degeneration also.
Okay. So basically, you know, there is some inflammation that comes along with any type of surgery that goes into the eye. So that can cause a little discomfort. But when you say, Stephanie, that it feels like there's something in the eye, that's probably more likely from dryness or tear film insufficiency problem. And for that, using an artificial tear, an over-the-counter artificial tear, not Visine or Get the Red Out drop, but an over-the-counter artificial tear will help a great deal. In the moment when it feels like there's something in the eye and you think it's an eyelash or something like that, and you're looking and you don't see anything, using an artificial tear 1 drop about every 10 to 20 seconds for about a minute will actually help to bulk up the lubrication, and that will help to get rid of the symptoms immediately. And then using a drop about every hour for the rest of the day will help to keep the eye nice and lubricated. Now, if it's severe pain, then that is something that you should call your retinal surgeon to address. If it just feels like there's something in the eye and the artificial tears take care of it, I would alert the retinal surgeon at your next appointment to make sure that nothing else is going on.
Thank you, Stephanie. Stephanie calling us from Slidell. Cheryl calling us from Slidell. We've had a couple, ratings must be high in Slidell tonight. Cheryl on line 1 calling us. Cheryl, welcome. You're on Hello Health with Dr. Kefla Brown.
Hi. I'm calling because I have a growth on my eye, and I think it's called the PT. Hi, I'm calling because I have a growth on my eye. I think it's called the PTERYGIUM.
Yes.
And I've been thinking about getting it removed because it's really getting larger. And I'm also experiencing some tingling or twitching in the eye. And the twitching is very uncomfortable. And I wanted to know if they're related. Or should I get this removed and the twitching will stop? Or I don't know. I just don't know what to do at this point.
I just had a quick question. Is the growth on the eye itself, or is it on the skin around the lid?
It's around the lid.
On the lid, not on the eye itself.
Right.
Okay, just
So what she's describing is actually what's called a pterygium, and very good spelling, Cheryl. So a pterygium is actually a growth on the conjunctiva. Okay, it starts on the conjunctiva and then it spreads to the cornea, and it's due to a lifetime of exposure to UV rays. It's not cancerous, but what it does is it essentially interferes with the eyelid blinking. So if you remember earlier in the show, I said that the eyelids blink. When eyelids blink, they close shut like a zipper, and they kind of spread tears over the front surface of the eye. So if you have a bump like a pterygium that interferes with that, then it's going to cause the eye to not be lubricated properly. The tears are not going to spread across the front surface of the eye properly. We're going to get some dryness, and that's where the irritation comes from. So removing the pterygium, it's a surgery that's done, a procedure that's done in office by a corneal surgeon, and it's got a pretty good success rate. There's always a chance, however, that it could grow back. Okay. Now the question that we had about the twitching being related to it. It could be not. Exactly what you want to hear, right? So basically, most twitching of the eyelid is going to be due to either stress, fatigue, or caffeine intake. So if we're getting enough pain or discomfort from the dryness that's resulting from the pterygium, then that could induce stress that could cause some twitching. So immediate relief is going to be lots of artificial tears, because we have to supplement the eye's natural tears with lubrication. And if it's causing really bad symptoms where it's kind of starting to affect your daily activities, then it's definitely a good idea to talk to your corneal surgeon to get that removed.
All right, Cheryl, thanks so much. Just a couple of minutes left and 2 callers left and an email we're going to try to get to, Doctor, so we'll kind of move through these if we can. Line 4, Carrie calling us from Garyville. Carrie, you're next.
Yes, thank you for taking my call. I had experienced something with tiny dots that I would see all over the place just about a month ago.
Was it associated with a headache?
Hello?
Hi.
Yeah, Carrie, is it associated with a headache, the doctor was asking?
If it's associated with headache?
Mm-hmm.
No, I didn't notice a headache.
Okay. So a lot of times there are 2 distinctions that we need to make here, Carrie. So oftentimes we will see tiny spots that could be another description for floaters, but what's more likely going on is what's called an ocular migraine. So basically what happens with an ocular migraine is the patient will see a bunch of colorful spots, or their vision will kind of get dark around the sides, or there'll be shimmering lights, and that's often what precedes a migraine headache. There's a good portion of the population, however, that will get the visual ocular migraine without getting the subsequent migraine headache. If it becomes something that occurs on a regular basis, then there is a treatment for it. If it's something that actually just happens kind of here and there, then it's something that we just educate and kind of and monitor without treatment. So it's if we start to get migraine headaches, of course, then that's something that can definitely be treated with either by your primary care doctor or a neurologist. If it's something that starts to occur on a regular basis, however, we do have some treatments that can alleviate that.
Thank you, Carrie. And our final caller tonight is Jerry, calling us from New Orleans. Jerry, thank you for your patience. You're next.
Hello, Dr. Brown.
Go right ahead, Jerry.
Yeah.
Go right ahead with your question.
Oh, my question is about my wife. She's 85. She was diagnosed with Bell palsy in the left side of her face. Had a little displacement, and she's having a little trouble with the eye. So the eye doctor started checking her out from the beginning. He said it was just a matter of process of time, and she goes in to see the eye doctor about maybe every month or so, and he checks her out, and he said that the eye is improving, and her side of her face was kind of pulled down also. And they're telling us as the family that it's just a matter of time that this will work itself out. I appreciate your time or any suggestions that we could do or any other specialties that we could give her for her.
Thank you, Jerry.
That's a very good question. So Bell's palsy is actually, it's pretty common. So what it is, it's a paralysis of the facial nerve, and the facial nerve plays a role in eyelid function. So the facial nerve is actually what closes the eyelid. So what happens in a Bell's palsy is, of course, one side of the face will droop, but with the eyes, we decrease that function of eyelid closing, so we get exposure of the front surface of the eye, which leads to tear film dysfunction and dryness. So in those early days and early weeks after a Bell's palsy, what the treatment is lubrication. So oftentimes when we go to sleep, we'll have to take the eyelids shut after putting in some lubrication and then using a lot of artificial tears to keep the eye lubricated. Over time, and usually over several months, a good portion of that function will be restored, but there's always a chance that it won't be 100% restored. In those cases, using artificial tears to keep the eye lubricated is going to be necessary. And if we're having a problem with the eye shutting at night, then taping the eyelid shut at night is going to keep the eye from drying out.
Okay, very good. That's it for our callers, but we do have one email we want to get to. Doctor, can you talk a little bit about the eye disease keratoconus? So what type of disease is it? What type of treatment options are available? Do you approve of corneal cross-linking to halt progression of the disease? This is from Ron, and Ron, thank you for the question.
So keratoconus is actually a corneal condition, and in pictures that I've shown before, the corneal is basically a spherical or round surface. In keratoconus, what happens is the cornea actually grows into a triangle or a conical surface, and it becomes very pointy. And what happens there is that front surface of the eye is disrupted, and when light goes in, it is focused in several spots in the retina instead of one clear spot. The standard treatment, initial treatment for keratoconus is visual, and that is using a very customized contact lens to fit the cornea, okay? And the contact lens essentially creates a new front surface so that that good vision can be achieved. Glasses usually don't work very well with keratoconus because with the glasses, light hits the lens of the glasses, but it still has to hit the cornea, and the cornea is where things get distorted. So now we actually have available a very good procedure called corneal cross-linking. So what happens there is that a riboflavin solution is actually applied to the cornea. UV light is then shown on the cornea to activate the solution, and the collagen fibers in the cornea are actually tightened. Instead of being in order, they're actually cross-linked and tightened, and that actually strengthens the cornea and slows down the progression of keratoconus. So 5-10 years ago, the final treatment for keratoconus was a full thickness corneal transplant. Nowadays, we can do UV corneal cross-linking in a much earlier stage and reduce or halt that progression significantly.
Encouraging news for those
Yes.
with keratoconus.
Yes, definitely.
Well, Doctor, we want to thank you very much for the information and education you provided tonight and for your work in the Oxnard Health System. Thank you so much.
Thank you so much. It was a pleasure.
A great guest.
Thank you.
Look forward to your third visit on this program. And that is our program for tonight. To make an appointment with any Oxnard physician, including tonight's guest, Dr. Kefla Brown, or to register for any of Oxnard's Hello Health seminars, we've got a phone number set up just for viewers of this program. It's 504-842-5669. That's 842-5669, and that'll get you on the fast track. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Oxnard's website at oxnard.org. Our thanks again to tonight's guest. Thanks to Humana and Oxnard for making our program possible. And our final thanks, as always, is reserved for you, for your support of this program, Hello Health, and our station, WLAE.
Hello Health on LAE is presented by the Oxnard Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxnard Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxnard, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.